Well, thank you very much indeed, Jeff, for those encouraging remarks. And I really want to thank Julio both for inviting me to this meeting and also for being the person above all others who's really driven us forward and kept our eye on the ball in regard to the importance of using treatment to stop and ultimately control the epidemic. So Julio is really the person who deserves a great amount of credit for what he's done over the last years. And this meeting is just an example of the great work he's done. And I think everybody is now convinced that early treatment offers us the best possible prospect for controlling the epidemic. There are many problems to be addressed, many operational problems, and Christoph has outlined a lot of them. Some of them we thought were problems, like this problem of the acute phase, which he and I think, agree is not as big a problem as we thought. And all of those operational problems have to be addressed. But what I want to do in a way which I hope will complement what Christoph says is we all agree that treatment is the best way to stop the epidemic, but then the question is, who should we test and who should we treat? And this has really been raised several times this morning and indeed last night. And what I want to do is to think about this purely in relation to the benefit of the individual patient. I think we all agree that we cannot put our public health demands in front of before the interest of the individual patient, and if treatment as prevention is harmful to individuals, we have a big problem. And I want to really ask three questions. If we're going to use CD4 cell counts to guide us in our decision-making, at what CD4 count should we start people on treatment? 200, 350, 500? It's all quite arbitrary, and we need a sound and rational basis for these decisions. Perhaps you will decide, as Max Essex is doing in Botswana, that viral load is a better prognostic marker for progression, in which case the same question arises. If we're going to start treatment based on viral load, at what viral load should we start treatment? And then, of course, if we test people if they're negative, how often should we test them? So I just want to focus on these three questions, but thinking of the individual patients. So the first question is, if we're going to use CD4 cell counts, when should we start treatment? And it seems to me that this is my hypothesis, this is my proposal, other people can come up with their own. A reasonable proposal is to say that we should treat people if they are likely to die within 2 years, if they don't have treatment. You could say 1 year, you could say 3 years. I think 2 years is a reasonable number. We're going to base this on their CD4 cell counts. And of course, we don't know for certain whether an individual person is going to live or die. So we have to make some kind of probabilistic statement. And I think we could reasonably say we should treat everybody if the probability that they will die in the next 2 years without treatment is more than 20%. Again, we can make 10% or 30%, whatever you like, but we need to put a number on that. So what I'm going to do is say, at what CD4 cell count should we start people on treatment if we want to ensure that the probability that they die in the next 2 years without treatment is less than 20%. And of course, if they get other opportunistic infections, tuberculosis or whatever, then immediately they start treatment. But what if they appear to be otherwise healthy? Now, the problem is, it's a slightly more difficult problem than you think it's going to be at first sight. A lot of data goes into this model. The first thing we know is that survival varies enormously. Some people will die within 2 years, some people will live for 25 years without treatment. There's enormous variability in the survival time. We know that survival depends strongly on age. If you're infected at age 4, you're going to live for 16 years on average. If you're infected at age 70, you're going to live for 4 years on average. So we need to put that into our model. We know that survival depends on your set point viral load. If you increase your set point viral load by a factor of 10, 1 log, you reduce your life expectancy by 8 years. We know that CD4 cell counts are enormously variable, both within and between populations. In South Africa, and this is all for HIV-negative people, the viral load varies from 500 to 2,500. So maybe these people should be put onto ART before they've even become infected because they've got a viral load of 500. So enormous variability within populations. And what we see is in Botswana, people have roughly, on average, half the CD4 cell count that people have in South Africa. So if we say 500 in South Africa, what are we going to say for Botswana? We need to bring all of this into our model. The incidence, of course, varies enormously by country, and this determines the risk this tells us how long a person is likely to have been infected for. So in Zimbabwe, the peak incidence was almost double what it was in South Africa. Now the incidence is roughly half what it was in South Africa. The incidence, the prevalence of infection in Zimbabwe are dropping like a stone for reasons which none of us understand, but not because of early treatment. We also know that transmission varies strongly with viral load, as Christoph Fraser was the first to point out clearly. It increases quite strongly with viral load when the viral load is low and saturates at high viral loads, again, for reasons which nobody has adequately explained. But all of these things need to go into the model, so the model is quite a complicated beast. But the beauty of mathematics is precisely that it enables us to take these very complicated sets of data and bring them together and synthesize them into something which will enable us to make sensible public health decisions. And what the model, I'm just going to show you the results of the model. I'm not going to take you through it, but what the model is going to tell us is what is the prognosis for an individual person if we know their country, their age, and their CD4 cell count. And the answer looks like this. So if we start in 1990, so very early in the epidemic, this is the CD4 cell count below which people in Zimbabwe, South Africa, and Botswana should have been put onto ART, of course, if it had been available then, which we all know it wasn't. So in 1990, we should have been thinking about starting 20-year-old people in Zimbabwe at about 450, people in Botswana about 300. Why is it lower in Botswana? Well, because people in Botswana start off with only half the CD4 cells that people in South Africa or Zimbabwe have. The CD4 cell count at which we should have started treatment increases slightly. So at age 50, we should have been starting at 600 in Zimbabwe, maybe 400 in Botswana. And amongst much older people, we should have started much earlier. And of course, the reason is simply that very old people have a very short life expectancy, so they're much closer to death than younger people, so we need to start them earlier. But that's all historical stuff. What we really want to know is what is the situation today? So if we do the same model for today, this is what we get. What we find is for 20-year-old people, by definition, they're only 20 years old, they can only have been infected recently. They can also start, as they did before, at about 450 in Zimbabwe and about 300 in Botswana. But everybody over the age of 35 has to start immediately. And that is clearly in the best interest of the individual patients. At the age of about 30, we might say, well, people in Zimbabwe and South Africa should start at 600, people in Botswana should start at about 400. But if you're really concerned about the best interest of the individual patient, we really do need to start a lot earlier than we're starting now. And indeed, everybody over 35, which includes me and I think Julio as well, should start immediately. Okay, so our recommendation might be something like, if we're really going to use CD4 cell counts, everybody aged 20 to 35 in South Africa and Zimbabwe, they should start at 550, in Botswana at 400, and we need to do this calculation for every country which has different CD4 cell counts in HIV-negative people, different epidemic curves, and so on. Above the age of 35, everybody should be started immediately on treatment in their own best interest. But maybe we should rather use viral loads, because we know that CD4 cell counts are highly variable within and between populations. So maybe maybe viral load is a better prognostic marker of your future prognosis. So we'll do exactly the same thing with viral loads. We'll say we're going to treat everybody if they are likely to die within 2 years. Now we're going to base it on viral load, not CD4 cell counts. But again, we're going to say everybody should be treated if the probability of dying in the next 2 years without treatment is more than 20%. Exactly the same calculations for viral loads. What we see is that, first of all, there's much less variability between countries because set point viral loads are much less variable. And in 1990, we could have said, well, just about everybody should be started when their viral load, if their viral load is above about 100,005 logs. Again, with very old people, we need to start earlier because they're likely to have been infected for longer. But 1990 is now well past us. The question is, what is the situation today? And the situation today is that if we really want to think about the best interests of our individual patients, again, even based on viral load, everybody above 35 really needs to be started on treatment immediately in their own best interest. Again, for young people, by definition, they've been infected earlier, so the CD4 cell count at which we could consider starting them on treatment remains high. But what it's telling us is that if you're 20 years old, you could start at 100,000. If you're 30 years old, you should start at 10,000. And if you're 35-year-old, you really must start immediately. So this hopefully puts some more rational basis onto these decisions. And our recommendation could be then something like those aged 20 start at 100,000, 30 at 10,000, and 35 essentially immediately. At least it does have the merit of being much less dependent on the particular epidemic in the particular country that you happen to live in. But supposing we do all of this, and then, of course, a lot of people we hope are going to be HIV negative, the other important question which we need to think about is how often should they come back for testing? And this, of course, is going to depend on the incidence, the future projected incidence. If the incidence is very low, they can come back after a long time. If the incidence is very high, they should come back more quickly. And again, we need to think about some kind of more sensible criteria, some rational criterion for making this decision. And the criterion that I suggest, and you can change it, you can make any decision you like, but you have to make a decision, you can't avoid making the decision, is that we should retest people if their chance of being infected when they come back again is 5% or more. You could say 10%, whatever you like, but you have to make a decision. You cannot avoid making this decision. For me, 5%, if you have 5% or greater chance of being infected in 1 or 2 or 3 years, you should be retested. If we do this for Zimbabwe and South Africa, what we see is that in South Africa, people between the age of 20 and 30 should come back essentially after about a year. People in Zimbabwe between the age of 20 and 30 only need to come back after 3 years because the incidence in Zimbabwe is much less than the incidence in South Africa. Again, for younger and older people, you might say to them, well, you can come back a little bit later because the incidence of infection in very young people and very old people is much lower. But again, we need to put this whole decision-making process onto some kind of a rational basis. And so our decision for when people should return for testing, we might say, well, those aged 20 to 30, in South Africa, they should come back once a year. In Zimbabwe, they should come back every 3 years. And people who are younger and older could come back less frequently. But we have to do this properly and sensibly. But we come back then to the question we really started with. And it has been much discussed already at this meeting. Is there any reason to believe that starting ART early might be harmful to individual patients? Now, Myron Cohn's HPTN-052 study has shown some evidence that starting early has clinical benefits to the individual patients. The Washington meeting will hopefully hear more about that, and I hope what we're going to hear is that there are even more benefits than we thought. And it's true that at the moment there's very little evidence about the benefit of starting treatment very early, for the clinical benefit for individual people. But there are two very important sources of data, I think. The first one is this. In around the year 2000, Jean Humphreys in Zimbabwe did a study called the Vitambo trial, in which they had 14,500 mother-child pairs who were followed up for 1 year postpartum. And what they did was they looked at the mortality, the 1 year mortality in these women as a function of the CD4 cell count, as a function of their CD4 cell count. There was no ART was available, and so none of them were put onto ART. Not surprisingly, if your CD4 cell count was 100, your 1 year mortality was 100 times greater than it was for HIV-negative women. But what is interesting about this slide is if your CD4 cell count was 700, your 1 year mortality was 8 times greater than it was if you're HIV-negative. And the model suggests that even at the highest CD4 cell counts, your 1 year mortality is 3 to 4 times higher than it would be if you're HIV-negative. So I think this is very strong evidence that if you're really concerned about the individual patient, the earlier you start them, the better. The other source of data, which I think is very important, is a paper, a collection of data in a paper by Grass in J-AIDS, where they plotted the recovery of CD4 cell counts over time in years from starting ART. And if you start when your CD4 cell count is about 50, you go up to about 400. If you start when it's 400, you go up to about 800. When you start 600, you go up to about 1,000. So wherever you start, your CD4 cell counts go up by about 400. But the point is, if you start late, you're never going to get there. And it seems to me that this is very clear and strong evidence that as time goes by, from the moment you get infected with HIV, it is doing serious damage to your immune system, and you will never recover from some of it. So it seems to me that this is extremely good and important and powerful data advising us that if you're really concerned about your individual patient, then you really should start them as early as you possibly can. Okay. Now, we all know that stopping the epidemic will depend mainly not on the science, but on the political will, financial commitment, education, logistics, mobilization, and so on. But I do hope that the mathematics can help us at least to think more clearly about the complex processes and tell us what may happen under different scenarios and help us to make more informed choices than we have been making so far. Thank you.